Okay, I said I'm gonna do two conditions on the chronic disease list. So the first one I did was hypertension, and then the second one is gonna be diabetes type 2. Yeah, diabetes type 2. I think these are one of the most common conditions that you can get in South Africa, and I think most people relate to this one. And then we will look at diabetes type 2. Let's look at the algorithms. Let's look at diagnosis algorithms of diabetes according to CMS. So this is for type 2 diagnosis. So to diagnose type 2 diabetes, then we have to address other risk factors and do lifestyle modification as part of the initial management treatment. And then we measure the HbA1c every 3 months, and then depending on the control and changes in therapy, if we done any changes or any lifestyle modification, then you have to monitor every 3 months to see if it's gonna work. The target for HbA1c level should be less than 7. Then if the HbA1c keeps on being equal to or more than 7%, then we should check if the lifestyle modification are successful. Then if yes, then we'll have to continue monitoring the HbA1c every 6 months. So if it keeps getting stable, if it keeps being stable or getting stable, then there's no need to initiate therapy. Then you keep it like that, you keep monitoring. And then if no, the lifestyle modifications are not enough, then we'll have to consider oral hypoglycemic agent if there is renal or cardiac dysfunction. So that will be your oral treatment that will help to lower your glucose level. So this is important because if you are diagnosed with type 2 diabetes, you can't just skip these stages and go to maybe implementing insulin. If that happens, then the medical aid might not pay for your insulin. They need to see that you are following the steps. So before you add oral hypoglycemic treatment, you have to check other conditions. Is there any renal or cardiac dysfunction? If no, then is the patient BMI more than 25? If yes, then you have to initiate on metformin. Metformin helps for weight control and also for diabetes. So it's usually the first line treatment for most cases. So is the BMI more than 25? Then if no, then we consider either metformin or a sulfonylurea, depending on the plasma glucose. So if there are other conditions, if the customer or the patient has renal failure or renal condition or cardiac dysfunction, then you go straight to sulfonylurea agent. The doctor might have to start you on that. So as I said, this is where they get you. They will put classes of drugs. They will put classes of medication. They won't specifically say which medication. For example, now they said sulfonylurea. Then there is quite a huge range of sulfonylurea. And then in most medical aid, they would want to cover the cheapest one, which is according to PMB, they are covering something. Then if there is adequate control, then can continue using those agents, and you have to monitor the HbA1c every 3 to 6 months. So the goal here is to make sure that your HbA1c is below 7 or equal or below 7. And then if it's not, if then on oral treatment you are not controlled, then you have to optimize dose. Then you have to optimize dose of oral agent. So you get the dose might be increased or add another agent until maybe you are controlled. Then after those adjustments, then the doctor have to check if you are controlled or not. If you're controlled, then you have to check your HbA1c every 3 to 6 months. And then if no, then a patient have to, if you are on metformin on its own, then they will add a sulfonylurea. And then if you are on a sulfonylurea already, then they will add metformin as a second agent. Then if you have poor renal function, then they will consider adding insulin or thiazolinedione. The authorized prescriber will have to follow all these steps before they can add you on insulin. They can't just give oral agents and then they put you on insulin. Most probably the medical aid won't pay for that unless you've started from metformin and sulfonylurea and then follow through the steps until then you might until like you go into insulin. So you can't jump. So it is important as well that your doctor follows the proper steps. If they want to jump to maybe insulin, let's say you are type 2, they just want to jump from nothing to insulin, then they might have to do a very big motivation in that case, which is gonna be a very long process. They have to provide evidence as to why you can't use these other agents. Why do you have to start on insulin before they put it on PMB? I've seen it in practice where doctors or prescribers just skip step or just skips other agent and just want you to put on like the last agent, and then medical aid don't usually pay for such things. They even if it's on their formulary, even if it's on the on PMB, then they won't pay for it if the doctor skip all these steps and just put you on like the last option. They have to see the steps that you went through before they pay for anything. If there is adequate control, then they will have to check your HbA1c every 3 to 6 months. And if there's no adequate control, obviously they will have to adjust insulin or other agents. In the case where they haven't added an insulin, they will have to add an insulin as well.